females, that's 50-50. The median age is 84, the mean age is 82. And we have reports of underlying conditions in 85.8%, or 1,276 such cases. In terms of the total number of incident cases as of midnight Sunday the 10th, at that point 23,089, 23089. 3,031 of those were hospitalised, that's 13.1%. 386 have been admitted to intensive care at some point, that's 1.7%. 29.9% are healthcare workers. The male-female breakdown is 43% male, 57% female, and the median age is 49. And of 385 admissions to intensive care, we have 71 remaining in intensive care as of this morning. The number of clusters then, briefly in relation to both residential care facilities and nursing homes. In total, we've now had 428 clusters notified in respect of residential care facilities, 245 of which are nursing homes. That's an increase of 3 in the residential care facilities and 1 in respect of nursing home clusters. We now have 5,923 cases associated with those clusters in community residential facilities. 4,624 are in respect of nursing home residents. The hospitalisation rate is 7.4% for those residents of residential care facilities. That's 441 who were admitted to hospital, 312 of whom, or 5.3%, are nursing home residents. In terms of the deaths, 937 are residents of residential care facilities. That's 63% of all 1,488 deaths notified so far. 815 of which, or 54.8% of the total, are in respect of people who lived in nursing homes. And then of those deaths, 171 of those in respect of residential care facilities occurred in a hospital environment. That's 18.2%. 143 of the nursing home residents' deaths occurred in a hospital environment. That's 17.5% of all 815 nursing home resident deaths. In respect then of some additional information in relation to clusters in other settings, in respect of prisons, we've had 5 reported clusters accounting for 18 cases, 2 of which have been hospitalised, and that represents no change since the last set of data we gave you. In respect of the Roma community, 3 such clusters accounting for 21 cases and 7 hospitalisations. Again, that's no change. In respect of our travelling community, 5 clusters, an increase of 2 since we last reported to you, accounting for 43 cases, an increase of 19, 2 of which have been hospitalised, which is an increase of 1 since we last reported to you. In respect of direct provision centres, a total of 12 clusters thus far, accounting for 149 cases, an increase of 61, and 12 of which have been hospitalised. That's an increase of 2. And then in respect of meat processing plants, we now have a total of 12 clusters reported. That's an increase of 2, accounting for 500 cases, 500, an increase of 133, 12 of whom have been hospitalised. So I'm going to introduce you to my colleague Rachel Kennett from the Office of the Chief Nursing Officer, given that it is the International Year of the Nurse, and today is a special day, and she's going to say a few words by way of an introduction. Rachel.
Thank you, Tony. Yes, today is a very special day in the calendar for the nursing world. It's International Nurses Day 2020, and that is contexted in the WHO declaration that 2020 is also the International Year of the Nurse and the Midwife. Now, we didn't expect to be celebrating this day, or indeed this year, amidst a COVID pandemic, but here we are. And in the context of today, nursing work very much as part of the large multidisciplinary team. But given the day that's in it, I'd like to particularly acknowledge the nursing response and midwifery response to COVID-19. Nurses and midwives are delivering care in a very different way through full PPE. That's both physically hard, but it's also missing the human contact, the close proximity to patients, which is very important to how we deliver our care. We're delivering care in very different locations, out of hospital, places that care didn't exist before, such as clinical assessment hubs. We've embraced technology in order to reach out and to maintain patients safely at home and reach specialist groups such as mental health and people with intellectual disabilities. I'd also like to acknowledge the personal sacrifices that nurses have made in the response to dealing with COVID-19, from limiting contact with their families to protect high-risk and vulnerable people, and also in initiatives such as they no longer live with their colleagues and friends. They've had to separate and live in accommodation that has been provided for them, so in order for us to be able to continue to provide safe and quality care.
Thank you very much, Rachel. So we now are happy to take any questions that you might have. Richard.
Richard Chambers from Virgin Media News. Just in terms of the daily number of confirmed cases, 107, that's the lowest figure we've seen since the end of March, by my understanding. Would that be encouraging with regards to moving along into phase 1 of the lockdown easing?
We've been clear about the progress that we needed to make over the course of this week, and I think for the most part, I think we're seeing that. We want to see further progress. I will still point to the fact that we have 70 people, or slightly over 70 people in intensive care units as of this morning, and almost 600 people in hospitals with this disease, even if those numbers have continued to fall over the course of the week. And we'll keep up our monitoring of all of that data over the course of the week and make our final assessment on Thursday in relation to where we think we are. We think we're making good progress, as I say. Our reproduction numbers where we want it to be, and the level of infection that we're detecting in the community now with the positivity rates, and we'll hear a little bit more of this now from Killian, I imagine, in and around 3% is giving us a sense of encouragement in relation to where we will be and our readiness to move on. But that's not me saying that today is the day. If we're going to be easing restrictions, it will be in respect of an assessment we'll formally do towards the end of this week and in respect of next Monday.
Just with regard to face coverings, you discussed that at NEFIT today. Could you just tell us what sort of guidance is going to be issued on that? Are people going to be encouraged to wear that in certain settings or certain environments?
So we'll come back to that issue again on Thursday and give it a little bit more precision in relation. But yes, as we've said all along over the last couple of weeks since we presented our advice on the roadmap, if you like, to government, we do see that in the community settings that there will be a role for face coverings that are not of a medical grade. We don't want a competition, if you like, for access to essential personal protective equipment that is designed for healthcare use in healthcare settings by healthcare professionals, or for people who've been directed by a doctor to wear a mask for medical reasons. So this is of a different grade, if you like, and we will be doing practical communications about one, what the nature of a face covering is and how people might be in a position to in some cases to make those for themselves, and these are things that you'll have seen probably on the internet in other countries and so on, and there are lots of examples of that available for people to see. So practical things that people can take, steps that people can make to provide those for themselves, but probably more importantly, guidance in relation to how to safely use them, because the message and the evidence is clear. If face masks aren't used properly, it can have the effect of actually increasing the risk of transmission. The face mask becomes contaminated. If it's touched, it can lead to infection being spread onto the hands. If people don't keep up the standard of hand washing and keep up the practice of social distancing, in fact, it can lead to increased risks as a result of that. So we do want to get that message across. There is a right way to do it. It does not protect you fully against the virus. It will be important to take the other measures in terms of social distancing and hand washing and so on. So we'll be emphasising all of those things as we roll out the communications and give consideration to the kinds of settings in which we think the use of these kinds of face coverings will be important. So it will be places where, as we ease restrictions, and we hope to be in a position to move in that direction, where people might be find themselves in settings where social distancing can be more of a challenge, so perhaps in retail environments or perhaps in relation to transportation and so on. But we'll set that guidance out as we go on through the course of the week.
Just in relation to testing then, Killian, yesterday we heard from the HSE that from referral to the start of contact tracing, once the result has been provided, is about 5 days. That's surely too long at this point. Could you give us the update, or is there any more up-to-date data on how long the testing process is now taking to turn around?
I might take that, that's okay. So you're right, the median time is 5 days. It is a complex pathway, but it's been shortened considerably, and we need to shorten it further again. So at this stage, the great majority of people who are referred for testing after they present are done within 1 day, and then 1 to 1.5 days, but 85%. and then the next stage is the result of the lab. From then until the lab result takes about 2.5 days. Contact tracing of the simpler variety, the non-complex contact tracing, usually takes place for the great majority again on the same day as the lab results comes out. So we've tightened up what is a complex logistical pathway. Our aim is not just to focus on the numbers, as we said, to get to 15,000 a day by May 19th, but to tighten that turnaround time from its current median time approaching not just 5 days, but heading towards 4 days, and to get it lower again, perhaps towards 3 days. But I'd have to emphasise, it is a complex pathway. It involves referral, it involves people getting swabbed, it involves conveyance to labs, it involves then the triggering of contact tracing. In the hospital, where the patient is in one position, we can get that done in 1 to 2 days for the great majority of cases. It's worth bearing in mind too that we understand much more about this virus than we did only a month or two ago, and we understand what's the importance of pre-symptomatic transmission. So we would urge people that rather than wait and wonder about their symptoms, to present very early with symptoms, because we know now what we didn't know a while ago is that during those 1 or 2 days before you get symptoms, you're potentially infectious, but more importantly, when you're aware of symptoms, for every day that you wait, that's a further day that you could be potentially infecting other people. So we would urge people to refer themselves as quickly as possible to their GP so they can get swabbed and tested.
Killian, do you have an update there in terms of total number of tests completed at this point?
So yes, the total number of tests completed is 258,808. So within the last week, we've done 44,047. Of those, 1,466 were positive, for a positivity rate of 3.3%, and that ranged from 2.2% to 5% over the course of the week. From a capacity perspective, we're probably up in the region of 90,000 plus now, so still well on track to meet the target, I suppose, of 105,000 at the start of next week. But I suppose the important thing, or one of the useful things for us, I suppose, in the past week, is that the broadening of the case definition hasn't swamped the system as has happened in the past. So we've still plenty of spare capacity. Probably gives us a little bit of room in the coming weeks to broaden out the case definition further. We're still, I suppose, aware anecdotally of maybe cases that aren't coming forward or aren't being tested because they don't have the typical symptoms. And as Colin alluded to, we're learning more about the disease all the time. So there are less common symptoms or new symptoms that we're associating with the infection. And as I said, anecdotally, we know maybe some GPs aren't referring those forward because they're not, strictly speaking, within the case definition. So we're keen to broaden that out. We want to test more. We want to drive down that positivity rate.
Quick one, just
Sure.
in relation to Ryanair. They've said that they want to open up their flights. 40% of their flight capacity would involve over 130 flights or routes in and out of Ireland in July, with PPE, masks being used on flights. Would you be comfortable with that at this point if Ryanair were to, or airlines were to decide to start to restore routes ahead of time?
So I'm not commenting on Ryanair particularly, but obviously our position at the moment is we're advising against all non-essential travel. I don't envisage that position will have changed within that time frame.
Hi Tony, Conal Thomas from the Journal.ie. Colin, just follow on from Richard's question there in relation to the gap between, say, a swab being taken and contact tracing commencing. You're explaining what exactly happens in the process, but can you tell us why there's specific delays in some cases, some people getting over 5 days? Can you give us a bit more detail on that?
That's a good question. If you look at the pattern of transmission and the pattern of the virus in our society, it's gone from being the contact tracing exercise, which is the whole purpose, which is of the testing to trigger that and to break the chain of transmission of the virus, has gone from being relatively high volume and low complexity to now low volume and high complexity. So the whole pathway of the median 5 days approaching 4 days now is from a referral to swabbing to testing to lab result to contact tracing, which, as I say, is for the non-complex case takes place on the same day for the great majority of cases as the result comes through. The problem we've had, and has been highlighted by some of your questions here and elsewhere, is on the more complex cases, which are carried out by public health departments of contact tracing. And there might be, for example, someone who's intensive care unit, someone who might not speak English, someone in a long-term residential care facility with communication difficulties, and so on, or even somebody who may have passed away. And these are more complex contact tracing exercises which are carried out by the public health departments. And through no fault of their own, those have taken longer than they should. And what we've done now this week is we now have a new public health lead for this pathway alone, and we're integrating it with our existing pathway for the non-complex cases, with the aim of producing the same dashboard of performance, i.e. a median time of 5 days, 4 days, and hopefully getting to 3 days.
So those specific cases you mentioned there in relation to the complications, those are the ones that are taking over 5 days or longer?
Generally speaking, it's the complex cases carried out by public health departments, which are more labour intensive, and they're called complex for a reason, which may involve healthcare workers who are working in vulnerable settings from the point of view of transmission to vulnerable people living in congregated settings where there may be, for example, communications difficulties, and where there may be difficulties establishing contacts and so on. So the delays that you're asking us questions about are largely in those cases. And there's examples of very good practice by public health departments in the Midlands, for example, where they're pursuing these down and carrying them out the same day or the following day from getting a result. And there's others where we don't have the same performance. And frankly, we have to make sure that we have a standardised performance right across the country, so we can give assurance to people that we're carrying out that contact tracing, not based on where you live, but based on a standardised way of performing and assuring the population we're carrying this out as quickly as possible.
Cillian, you mentioned last week in relation to, you were trying to figure out exactly where delays are specifically in relation to test turnaround in labs and stuff like that. I mean, we were told reagents was an issue. That's not really an issue anymore. We were told lab capacity was an issue. It's not really an issue anymore. Swab's the same. So where are the delays in the labs?
So I think there's no single fundamental issue at any one point. I think what we're seeing now is the effects of scaling up a new system over a very short period of time. So there's no single fundamental problem. What we're seeing from some of the cases that you're describing is that there are still manual steps in this process from start to finish, and unfortunately errors will happen in that situation, and the HSE is working very hard to automate those steps. We're seeing issues where there will be transcription errors. Equally, if we don't get all the data, so that includes sort of mobile phone numbers for the patient themselves, contact details for GPs, then unfortunately those results take time to then track down how we can best get them back to the patient. But a lot of that will be automated in the coming weeks. But ultimately we're in a situation where we're testing in the region of sort of 50-60,000 tests a week in a system that was put in place 8 weeks ago. And it is a new system. It's really important to sort of highlight that to people. We've had traditionally we get referrals from GPs and from hospitals, and all of that is electronic. It's been set up over a number of years, but a lot of our hospitals, and including ourselves, we all operate on different computer systems, so they don't all talk to each other, unfortunately, very easily. So that takes time to build into place, and it takes time to make sure that it's robust. We don't have a unique patient identifier yet. We don't have a national laboratory information management system. So making sure that all of these systems can talk to each other, and for anybody who's ever tried to get a PC to talk to a Mac, you know what I mean, these things take time, and it's really important that it's safe and it's robust. So as that, adding in the human element, which we're working on through automation, but also automation doesn't just happen with the flick of a switch. There's a huge amount of script and coding. As I said, it's over my head, a lot of it, but it needs to be put in place, and it needs to be designed from scratch, because this is a brand new system. So as I said, I think we know we need to get better, but it's a huge improvement on where we were. We want to get the turnaround time down, and as I said, when that gets automated and the not detected results can go out by automation through a text back to the patient, then we'll be in a much better place, because then we can focus on the number of detected cases, and obviously, thankfully, those numbers are coming down. So the turnaround times will get better, but as I said, it's the old cliche of a lot done, more to do.
Tony, finally for yourself, what we're speaking about now in terms of the delays and certain cases taking longer, especially lab turnaround, etc., how does that inform, I suppose, any recommendation ahead of Monday?
So we'll keep all these things under review. In other words, the path of the disease and the progress around that, our hospital capacity, our contact tracing, testing, sampling process, and all of those are set out in the government roadmap. In other words, the broad framework for decision making, the advice that we provide, and we'll continue to monitor that over the course of the week. I think some of the things that Cillian and Colm are talking about in terms of where we stand now and where we expect to be over the course of the week, there's still improvements to play into that. And I'd still be hopeful that we'll see some of the improvement that we need to see over the course of the remaining part of the week.
Thanks very much.
Thanks.
And Jack Horgan-Jones from the Irish Times. Cillian, can I get you to give us a time frame for those changes that you just described there, the various systems talking to each other, the elimination of manual processes? How long is that going to take to complete? When are we going to be at a time frame of turning around this whole process within 72 hours?
So I can't give you definitive timelines on those, Colin. I don't know if you have an update on the automation process at this point.
It was semi-automated in terms of close contacts from May the 12th. It'll be fully automated from May the 19th for contacting close contacts, and that would be informing them their close contact and asking them to contact again. To phone back when it's semi-automated, if they have symptoms. When it's fully automated, it'll allow them to contact by text.
And how about the systems talking to each other that Cillian mentioned, the Apple? And
I can't give you a timeline that, but I'll come back on that.
You don't even have an indicative one? You'd like it done by the end of the month? Or?
I just don't have a timeline on that, I'm afraid.
Paul Reid indicated that there was going to be a new kind of testing plan. He also gave a kind of ballpark cost of around €1 billion on Sunday. Is there an update on where that is at?
Sorry, on the testing?
The new testing plan that Paul Reid, he alluded to it on Sunday. He said it was going to cost around €1 billion. I understand that there's negotiations going on between the department and the HSE over the shape and size of that. Can you give an update on that?
Yeah, well, the testing plan that we put together with the department and for NEFIT, it itemises our step-by-step incremental approach to 15,000 tests per day by May the 19th, and that we expect to be at that capacity by May the 19th. That doesn't mean we'll be doing 15,000 tests a day by then. It'll depend on what the focus of our testing is based on public health advice. Currently it's based on the case definition and on completing the nursing home and residential care settings, which is now complete, and whatever other measures public health direction through Lorraine Doherty and the head of health protection, the HC, will advise NEFIT to pursue. So as to the price, it's not my domain, but our aim is to have an end-to-end 15,000 process for 15,000 tests per day by the May 19th, and we're achieving that. We have that capacity in place already, but the demand is not yet there.
Tony, just one question on, we're seeing a bit more detail come out about the UK's plans for exiting lockdown, and also today some detail about how the North is going to proceed. Do you have any views on what you've seen from across the water and over the border?
So we're looking at those plans, and we've seen the plan. I haven't had a chance to study the plan from Northern Ireland in great detail. I've had some contact with my counterpart in Northern Ireland. We'll be giving consideration to that over the course of this week. Obviously, different countries are in different places at the same point in time in relation to the disease. The track of the disease in this country is probably at a slightly different point here than it is in relation to, if you like, the island of Great Britain. We think in broad terms the disease is behaving the same, and we're having a similar experience in terms of disease here on this side of the border, on the island of Ireland, that our colleagues in Northern Ireland are having north of the border. And I think they've set out a slightly different plan in terms of phasing. I think there might be 5 phases, which is a little like ours. And I think in broad terms, the steps that are provided for in their plan, and again, as I say, I haven't had a chance to study it in detail, I don't see significant variations between it and the plan that we have set out and that government has produced here.
And given Gabriel Scally, for example, has said that he would like to see a closeness in how the North and here proceed in terms of lockdown, would you welcome similarities between the plan that you're seeing in the North and the plan that we're embarking on here?
I share Gabriel's ambition, and we've a framework in place, an agreement that was developed between my counterpart and I, and endorsed by the 2 departments and the 2 governments to provide for exactly that cooperation across a number of different headings between the two sides of the island on a range of things where we can find common ground and where it makes sense for us to work together, and we will continue to do that and continue to stay in close touch. We share the island, and it's a single disease, and we want to try and bring as much commonality to our 2 approaches as we can. Thanks, Jack.
Robert Hanrahan, Jody. Dr. Henry, can I just ask, you said there in terms of the turnaround time that we need to shorten it further. Now we're 6 days out from the lifting of the first phase, and we've had a couple of people raise concerns around the testing capacity and the testing capacity turnaround. Professor Paul Moyna of Minute has told us that there's no point in having 100,000 tests per week if the speed return is 5 to 7 days. Dr. Tomas Ryan from Trinity has said that we are driving the car off the cliff if we go ahead next week. And then Dr. Mary Favier of NEFIT and the ICGP has said that there is evidence that the later it goes before you start to chase up these positive results, the less effective that is. does that need to be turned around before we loosen things next Monday, or is there the potential that, as Dr. Mary Fabier said on Morning Ireland on Monday, that this may affect lockdown being lifted on Monday in the first phase?
Well, the short answer to your question is that's a decision for NEFIT based on the testing capacity and who we're testing and the testing performance. What I can say, in the hospital system, we are able to do this in one day in many cases, and not most cases. In some hospitals, such as Beaumont, they have same day testing, same day results and contact tracing and so on. But the fact, and we would prefer to have the same performance in the community, but the fact is it is more complicated. People have to, because they're out in the community, they have to present with symptoms, they have to be referred to a place, and there's different steps in that pathway that go right through to contact tracing. And there, much as we'd like to have it down to 24 or 48 hours, there are logistical challenges in doing that. But we have, well, I can assure you we're working hard and have worked hard to get it down to 5 days. Now we need to get it down to 4, and it's approaching that now, and the median time down to 3. Every day we take off that, it means there's less possibility of somebody who's positive transmitting the virus. But the advice to people remains the same throughout that, is to self-isolate, and for their contacts, the advice is to isolate as well. So we are trying to get it down as quickly as we can, but because of the different steps in the pathway right through to contact tracing, it's difficult to get it down to the same performance as the hospital system.
Dr. Hewlin, can I just ask, the numbers given for direct provision, they're the same numbers that were given by Dr. Glynn last Thursday. They're as of midnight last Wednesday, is that correct?
Yes.
And we'll have updated figures for this week on Thursday, is that
Thursday.
Okay, perfect. Can I just ask, the HSE have confirmed this evening that the letter asked about in the last couple of press conferences that was sent to Carcevine direct provision residents was from the local Department of Public Health. And in that statement they said to us that the advice on self-isolation outlined in the letter is the same advice given to any member of the public who is tested positive or is a close contact. There are 1,700 people in direct provision who are currently sharing bedrooms with non-family members, according to figures last week. That's over 1/5. That's not the same as what's happening in the public. Do the residents of direct provision need specific advice given to them, and do they need, as well as that, specific provisions made for them as well?
Yeah, well, this is a particularly complex setting, direct provision centres, because again, it's a congregated setting, albeit of people of a younger age group. While transmission is a risk, we know from the figures of hospitalisation that the hospitalisation figures are much lower and the illness figures are much lower. But notwithstanding those issues, there's been particular focus by departments of public health, including the one in Carcevine, on outbreak management, and that includes a site-by-site inspection, looking at the layout of the facilities, looking how close they are together, providing advice on isolation. And remember, the residential facilities here are run by the Department of Justice, and working with the Department of Justice, in most cases the Department of Justice have provided accommodation themselves for self-isolation. In our own case, we provide, on top of that, we provide a facility in City West for some of the residents in direct provision centres to ensure that those who are positive are enabled to self-isolate. So the letter you refer to was issued by the local Department of Public Health following their own inspection of the facility and in line with their outbreak management in that particular facility.
Sorry, can I just check on that? The CWS facility is available to some direct provision residents, not all?
No, for people who require self-isolation and where that's not possible, where they live in the direct provision, the Department of Justice have provided alternative accommodation for most of such residents. We ourselves in the HSE have provided for some of the residents in the direct provision centres in City West, but most of those who required isolation elsewhere were provided by the Department of Justice in other facilities.
Thank you.
Shane?
Hi, Tony. Shane Beattie from News Talk. Just the figure that you gave for outbreaks in nursing homes, do you have that figure again?
Sure.
That we have so far?
So the total number of clusters in nursing homes, you're asking?
Yes.
245, and then the number of cases associated with that is 4,624, associated with those 245.
Okay, I'm confused because Anne O'Connor said at the HSE briefing on Sunday that it affected 371 nursing homes. So why is there a difference between that? Would we know?
I'm not sure of Anne O'Connor's figures.
Okay, so the official was 245 clusters.
So this is the figure that's based on the notified cases through the system of notification that's provided for in the infectious disease legislation, notifications coming up through the HPSC and reported to us.
Okay, perfect. Thank you. Can I ask about contact tracing? Are you happy with where we are at contact tracing, that we can stand over it? A lot of people have contacted me, including healthcare workers who live together, who say that they've had no contact tracing, and they're actually, healthcare workers, that they say none of their family have been phoned. can we say everybody who's confirmed positive that contact tracing is happening for those people?
I think, as I said earlier, Shane, where it's non-complex or simpler contact tracing, where performance is fairly standardised now. We know the great majority of cases are done on the same day that the lab result is uploaded, or in a smaller number of cases the following day, depending on what time the lab result comes through. We need to improve our performance in what's called the more complex cases, and that is, by their very nature, healthcare workers, people in residential care facilities, people perhaps with English language problems. The exercise itself is more complex by definition, but we need to improve that performance, and I can tell you there's a particular focus on that this week in the HSE to ensure that we align that performance with the less complex contact tracing, so we can give assurance to people and that these stories that you're telling about, which I'm absolutely sure are true, that we hear no more often. We need to tighten this up, as people pointed out. The longer people the contact tracing exercise doesn't carry out, the more risk we're carrying. So it needs to improve.
But I mean, people living together is hardly complex contact tracing, is it?
No, I can't comment on individual cases, but healthcare workers come within the band of contact tracing. I'm just giving illustrative examples of contact tracing, why it's devolved to departments of public health, and healthcare workers are included in that category.
Okay, is there more people themselves could do? Are we encouraging people to do their own contact tracing then?
Currently we feel that these cases are best performed by the specialists, people who are trained and who have expert knowledge in this, and that's the public health departments. What we're trying to do, which is probably getting at your question, is make sure that the tasks they previously had to do, which are not so specialised, are delegated to other people to free them up to carry out this work. And I suppose that's why our contact trace management programme, which was set up in 9 or so centres around the country, including UCD and elsewhere, that's why we have other healthcare professionals carrying out that less complex work. But I certainly wouldn't be comfortable, given the degree of specialty and knowledge required, of having anybody other than public health departments carrying out this work.
And just finally, very briefly, I know one day last week we heard that there was 40 people working actively on contact tracing on one day last week out of 2,000 trained. Do we know of any updated figures on a given day, how many people are working on contact tracing?
Well, forgive me if I'm confusing you, but that pertains to that contact management programme, which is the less complex work. And we did 1,800 people were trained. We flexed it up. The people we use are flexed up and down based on demand. And as I said earlier to one of your colleagues, we've gone to a position where we had high volume of cases and low complexity to now having a low volume and high complexity. So the demand has kind of waned away from that low complex contact tracing management programme. Hence the numbers who are actually carrying it out, which I think the latest figure might have been 80 or so, reflects the demand, not even more.
So that's 80 out of 1,800.
1,800 were trained, but we flex the numbers actively involved based on what the demand is coming through. And as you've seen from our figures earlier, other presentations, the number of contacts coming through from positive case definitions is lowering from a peak of 20 to less than 3 now, so there's less work for them to do.
Great. Thank you very much.
Thanks, Shane. Mark.
Hi, Mark Auckland from Primetime. Very welcome to see figures being provided on a daily basis now. Could you publish those figures? Like, instead of giving them orally, could we have them written down? Because obviously we want to avoid errors and make it as accurately as possible. So could you publish them so we fully understand the parameters on a daily basis?
Absolutely. That's our intent, to be as open as possible with these, because there's rightfully quite a lot of focus on this. We've been working hard to try and get these figures down to get the turnaround time as quick as possible, and it's in everybody's interest that people see these figures.
Thank you. The figures that you're talking about there, what period do they cover? How far do they go back? And are they 10 days, 7 days, whatever?
Yeah, the figure I'm giving you really pertains to how our performance has improved over the past week. As I said to you, from the moment the test is ordered until the contact tracing is completed and triggered and completed, which is usually that day 5. The median time is 5 days, but actually approaching 4 at this stage. So it pertains to the past week, and a tightening up of particularly the gap between when the test is ordered and the test is carried out in the testing centre, which is now down to, in the great majority of cases, that same day or the following day. 85% are within 1.5 days. And the other gap which is narrowed down was the triggering of that contact tracing from the moment the lab result is uploaded to the time that the 80 or so people who are actively engaged in contact tracing start making those calls, which again, in the majority of cases, is in the same day, unless the result was uploaded that evening, in which case it's the following day.
Thank you. A question for Dr. Holan, if you don't mind. We've, as a country, I suppose, and especially as a media, have gone through a crash course in epidemiology, and for a long time we've been talking about the reproduction number, and obviously that's far lower, but that is to some degree a retrospective number. You've referred to a serial interval. Is that number becoming more important, and do we have an effective serial interval for Ireland at the moment?
We do. It's in around 5 days. I'll get you the precise number, and that is part of the modelling data. The serial interval for those who is the period of time between when I become symptomatic, if you like, and the person who I might infect next will become symptomatic. That shortest interval, it's in around 5 days.
Okay, and that's part of the modelling?
It forms part of the modelling, and it's part of the if you like, the data that's looked at there, the modelling data, and there is a table of assumptions. I don't think I have it with me here with our direct experience. And maybe, Deirdre, I don't know if we have that table of, I can share it if I have it, otherwise I'll bring it for you tomorrow evening. But we have all of the data set out, so what our experience in this country is of all of the various different parameters, the incubation periods, the average incubation periods, the serial interval, and the period of infectivity and so on.
I think internationally it's 4 to 5 days as well. Is it?
Yeah.
I'm not sure if it's affected by social distancing measures. Like, would you be projecting that will shorten as restrictions are lifted, or what way would?
Well, we think all of the social distancing measures will have a significant impact on the reproduction rate overall. It makes a contribution, obviously, by reducing the likelihood of people coming in contact with other cases, and has a significant impact on the reproduction number, but not necessarily on the serial interval. The incubation period, but the period of infectivity then for us in this country, and it's in and around, I think, 6.5, 7 days in what's reported in most countries. I think it's 6.9. If I'll have to just check. But I have a table that sets out, if you like, each of these parameters and the assumptions that we make in the modelling. We had it last Thursday, and I can if Deirdre's in a position to put it up, I could share it with you now. Yeah, we'll have it in a second, Mark. Yeah.
A final question. In relation to home care workers, in other healthcare settings, and the definition of healthcare settings, I suppose, is up for question here. But should a home care worker be tested in the same way with a forehead thermometer, or whatever the proper word is, as people are when they go into hospitals, as I understand it, workers?
Are you talking now about temperature screening?
Yeah, sorry, I don't have the correct terminology.
That's okay. Like there isn't in place a blanket recommendation in relation to home care workers that there be temperature screening in relation to those before they go into houses. I think there are recommendations in place in respect of nursing home and other residential staff that they are checked symptom-wise at the beginning and during the course of each shift, and those arrangements are in place for them.
Would it be something to consider, or is it something that has been considered?
I mean, temperature testing does play a role in certain settings and can be used in certain settings. I think the issue with temperature testing in relation to this disease overall is that it can give false reassurance. The presence of fever, there are different variants of this, and Cillian would be more expert on this than I. In less than 50% of the cases you can have fever, and then you can also, people be aware that other things cause fever. And then also be aware that simple medications like paracetamol can be used to disguise fever if somebody's motivated to do so. So we think that screening in a general sense of temperatures in various settings has limited role to play, but it has been applied in certain healthcare settings.
Thank you.
Did you want to show a slide there? No?
I'll get a signal when it's ready, and we don't have it, I think, but I'll get it for you, Mark.
Okay. The summer's coming. I think everyone's hoping it's going to be a good summer.
I think it's just gone.
I was wondering about the science of it in relation to the virus. So, we know that during summers we tend to see a reduced level of flu, which is different, going around. But what can you tell us about, say we had a nice hot summer, what might happen in relation to the virus, just in relation to the science of transmission? Is there much known about that?
Well, there's a certain amount of scientific knowledge. I might come to Cillian on that particular point in a second, if that's okay. But also, there are effects that it has that relate to the virus itself, and maybe those are some of the unknowns. But then also the fact that in summertime people spend more time outdoors, they spend more time involved in outdoor activities, less congregation indoors, like for like. So the summertime tends to be a period in which you get less in the way of viral transmission for those reasons. Now obviously over the course of this summer we're going to be talking about starting, we're now in summertime, starting with a range of very tight restrictions in place that we'll be seeking to ease on a gradual basis as we observe the impact of that. So in that sense, it's not going to be a normal summer. And we'll be looking through the easing of restrictions. So the way in which summer in the normal course would play an impact on viral transmission. It might have some effect, but actually the thing that's going to have an effect or otherwise will be the extent to which, as we step our way through the easing of restrictions, as hopefully the public stays with us and stays with the measures that we've recommended, particularly the personal behaviours around hand washing, around respiratory etiquette, around, as we will recommend, the use of face coverings in certain situations, observing in terms of social distancing, staying away from crowds and crowded places in so much as they reasonably can. Following all of those kinds of measures will help us to minimise the transmission as we ease restrictions, even though we're in a summer situation. So the overlay, if you like, of a summer effect in viral transmission might be difficult to see over the course of this summer. Cillian, did you want to add anything just in relation to the virus itself?
Well, I suppose I can add maybe a couple of general principles, sure. Because obviously, as everybody knows, this is a new virus, so we don't know how it's going to behave during summer. But if we look at, say, something along the lines of influenza, as you alluded to, there are three factors that we typically take into account from a virology perspective. So you've got the host, you've got the behaviour of the population, and then you have environmental factors. So at a host level, so we still don't know why influenza, for example, is seasonal, definitively. The speculation, so from a host perspective, there's theories around vitamin D and sort of population level immunity in the winter. This is in temperate climates, obviously. From a behaviour perspective, obviously we congregate, we're indoors, there's lots of close contact, it's readily transmissible. Influenza is transmitted before people are symptomatic, so it's challenging in that respect. And then from an environmental perspective, again, it comes back to UV light, humidity. So it's likely that this virus in a very hot summer wouldn't survive as well in the environment on surfaces, but that's not going to affect how it survives in people. And obviously person-to-person transmission is the primary mode of transmission in this situation. But there are a lot of unknowns because it's a new virus. So, and as Tony has alluded to, hopefully our behaviour through the summer won't be a typical one.
And just in relation to, it's a difficult one, probably hard to answer really. Normally around 90 people die every day in Ireland if you look at the overall figures. And, you know, we're looking at 10 weeks of COVID-19, about 21 deaths a day. If you're just looking at it in those terms.
Where are you getting the number 21?
If you look at 10 weeks and you divide the number of, you have the number of deaths, and you look at the number of deaths per day, on average, you know, if you divide the number of weeks and the number of deaths we know about.
Sorry, go on, yeah.
Well, I'm trying to get a sense of excess mortality, and I don't know whether it's possible to even give a view on that now. But what I'm wondering is, do you have any sense of, at this point, where we are in terms of the number of deaths you would normally see in a normal year during these 10 weeks or so, and what we've seen in relation to COVID-19? What could you say about that? I mean, work has been done to reduce the number of fatalities, so that's going to feed into it. But is there any sense of, you know, the number of deaths you'd normally see, and then in terms of COVID-19, and how we've done in those 10 weeks?
So it's so a couple of levels to answer the question out. So we have seen an increase in the number of deaths over and above what we would expect to see, and we're looking at a number of different measures that give us a sense of that. If I can deal first of all with the deaths that we know have occurred in respective residents of nursing homes, community residential facilities, which combined account for almost 2/3 of the deaths that we've experienced in this country. We think we've identified much of that mortality. It is at a higher level than it would be in the case as compared, let's say, to last year, we think. But we think we've identified most of it and explained it as a result of it. And when I say explained, I mean accounted for it in the numbers of people where we have either lab confirmation or probable cases of COVID-19 identified. In the community, what we're starting to see is some level of excess mortality overall. But our information on that does lag a little bit. There's to point that out, and I've said this on a number of occasions before. The reason for that is because we rely for that purpose on notifications that come through the GRO. There's a 3-month statutory period that's provided for that notification. It is lengthy, and while many people will register deaths quite early in that period, they have up to 3 months, and there can be a spread, if you like. And one of the things that we think is happening this year is that as a consequence of perhaps fear, perhaps because of the arrangements that we have in place in terms of social distancing and so on, people are not coming forward to GRO offices and so on to notify, and in some cases those will be closed in any case, which is why the relevant department, the Department of Social Protection, has put in place an arrangement whereby people can make those registrations online. And we've been encouraging for some weeks now people to make those registrations online so we can have as up to the minute notification of mortality. It's a difficult thing for people to have to do, to fulfil that administrative function at a difficult time when people are grieving and trying to look after funeral arrangements and all of those kinds of things, so we do understand that. But it's one of the reasons that we wrote to funeral directors, as well as highlighting through yourselves over a period of weeks the importance of raising the family's notification to us as early as possible, so we can track that. We're part then at a national level of an international European trending or measurement of total excess mortality. And we understand the total excess mortality in the population. We'll see how much of it we have accounted for in terms of existing COVID-19. But we've been reporting at a much higher rate. When I say rate, I mean we've been reporting more categories, if you like. We've been reporting from nursing homes and residential facilities, which is not the case in many countries. We've also been adding to our reported deaths, not just lab confirmations, but probable, and we made that change about 3 weeks ago in line with the advice from the WHO. And so you have to take that into account when you're doing comparative mortality reports. Every country struggles with these kinds of issues and the timeliness of reporting of these. We're seeing that in respect of many countries in Europe, in spite of the fact that we're reporting much more in the way of categories, we think much more in the way of locations and residential facilities and so on than many other countries are doing. We're still seeing a level of mortality that's in line or below many of the big European countries on this side of the European continent.
Okay, just finally, maybe Dr. Colm Henry on this one. It was on radio earlier on Liveline. Just the issue about maybe carers, home carers, going from house to house, maybe not always wearing PPE, but the main point I think that was raised was that if a resident, a resident of a house, for example, not necessarily a nursing home, but has COVID-19, who's responsible for reporting that? Is it the company, for example, that might be providing the home care, or the family? There was an issue that was raised today about that.
Yeah, I'd expect it's the duty of the doctor and the public to report to the public health department, as is the case anywhere else, because it's a notifiable disease for good reason, and that's because we need to alert public health departments to instigate the actions necessary to reduce transmission wherever that may be, including in a home care setting. Okay.
If I might just add to that, what the legislation provides for, and that's how notifications happen, is either a doctor can make a clinical diagnosis and make a clinical notification of a prescribed infectious disease, or a laboratory diagnosis can lead to a laboratory making that notification as well. That's what the legislation provides for one of a listed number of infectious diseases, of which this is now one.
Because in the case of the family that was on radio earlier, they were saying that when they contacted the company, as far as we're called, they were told that they had to report it to the family, report it to the HSC.
No, statutory notification of an infectious disease is the responsibility of a doctor or the laboratory that makes the diagnosis. Yeah.
Thank you.
Yeah.
Ceist den Dr. Colm Henry sin beidir bhísleat Lordlín faoin dúirta seo hana a méarla beidir ach faoin tréimhse ama a chaithí duine fannacht ón uair an ordiator tastal dá go dtí go bhfuin an duine sin tarú. Cibhéad amatá gceiste na sin mar.
Mae gyda agus mae district canna méarla chorus uair tá ann servís uair cumid de chéile le si de chwplaní inis agus chorus casta tá an fosta. Ní bhain go bhfuil daoine dul am an tastaile cha si dul goí an candana honad tastála dús beire agus an sin tá si táhacht an tastáil sin a dul go dtí na síran agus an sin an torthais cethe an áthair agus an sin scratch a chur na iad san a bhí deagmhail. So chorus casta tá ann ach tá si roada agus tá bégan doing an chorus sin an tréise sin a gearú go fada féidir agus bégan doing fosta agus tá si Harbheith táhata doing fíomhar a chur leis an prósé seo. So fi láthar tá muín agin inis go bhfuil an tréise ag gearú a níos go dtí cúig láán an níos ísle ríis agus tá súlagin go mé muid abalta dul níos iste anon ná sna hospital tá sé tábhachtach chundia an duine sna hospital tan tréise sin anargeara fad tiis go bhfuil an ochar sitse stís an hospital agus bhfuil an choras tastáil an sna síharlan agus bhfuil na doctorí ná níl sé castar scalabe. So tá sé dul a bheabhas ach tá fever chaimid fever chur leis.
Gina McEnroe with the Irish Examiner, good evening. Can I just ask you, tomorrow the EU is expected to release guidelines on possible easing of restrictions for travel in the bloc and among member states. You talked earlier about the All-Ireland approach in Gabriel Scally's opinion. What are your thoughts on more stringent checking at airports and border points with the use of temperature checking or otherwise? I know the Health Minister today has talked about maybe the need to underpin those with stronger legislation. If I could ask you that question first, please.
Sure. So we've already provided advice as part of the advice we've provided to government in advance of the publication of the roadmap that we would need to have stricter and more mandatory measures in place in relation to ports and points of entry onto the island. And we provided some additional advice last Friday in relation to that, and I've said that already, and that's now under consideration by government. We think that will be important in terms of the measures that are in place as we move into an easing potentially of restrictions in the near future. So we've been clear on that particular point, and that it will need to be underpinned by some changes in relation to regulations that are provided for, which is what the Minister would have been referring to yet.
Which brings me to my second question. The issue of antibody testing. The Abbott test has found some favour in the United States. There's some discussion here because it has a large amount of employees, the company for the product. What's the position of NFET maybe and such an antibody test being conducted on a mass scale?
So we want to see tests that we think are reliable enough and have been tested at the kind of scale that it is needed to allow us to, as it were, rely on the reliability of those tests and to start to use those to understand what we call the seroprevalence and the extent to which there is true population exposure in relation to this disease, what we can, if you like, understand about it. So we have our case numbers of incident reported cases diagnosed through the PCR testing through the laboratories, but to understand all the cases that might have occurred asymptomatically in the population, we would need a reliable seroprevalence test. We know work is happening to validate some of those tests and to test them in larger trials, if you like, to establish that reliability. And when we're in a position, I think, to recommend one, we will start to use it. We've already had the work and we've been doing the work to try to work out, if you like, the organisation of seroprevalence studies, and all of that is now ready to go, as it were, awaiting a validated test that we think that can perform at the kind of scale that we need. We did some work through the Health Technology Assessment function in HICWA, where they pulled a report together looking at all of the various types of tests and which ones might or might not find value. We don't think we're at a point yet where we can recommend a test, but we're getting closer. I should also say, by the way, and draw your attention to, you may or may not have come across what the WHO has been saying in the last 24 or 48 hours in relation to seroprevalence and the extent to which significant levels of immunity and background immunity is occurring in populations as a consequence of infection with this disease, and really cautioning against the idea that large amounts of immunity is building up in populations through their experiences with this disease. And the concept, if you like, that has been spoken about in some countries around herd immunity. And so the WHO spoke, I think, quite strongly and clearly yesterday, cautioning against that kind of that view.
Okay, thank you. Just and very finally, we're hopefully moving towards that phase that was spoken about earlier of easing the restrictions next week. It's a new low figure this evening of 107 cases. On that trajectory or the model you're looking at, would you in the next 2 weeks expect cases to go to low double-digit figures maybe?
I'd like that to happen. I'm not going to put a target on it to the extent that, like, if we don't get to low double-digit, it might not be a reason for us to hold on where we're at. We look at a whole range of different parameters, including not just the number of cases, but the settings in which they're occurring. We look, as I said before, on the impact of that illness in terms of ICU admissions, in terms of admissions to hospital, and look at the extent to which we have a continuing presence of people in both hospital and ICU settings with this disease. And we will want to see, if you like, those trends being maintained over a period of time. So we're not just looking at a point in time, but assuring ourselves that it's a continued downward trajectory of the kind that we're seeing at the moment.
At this stage, are you confident we can go into that next phase?
I'm hopeful. I'm hopeful, but I'm to be cautious that, like, we have further progress to make. As I've said, we still have almost 600 people in hospital beds tonight who have this diagnosis. We have 70 people as of this morning in intensive care unit environments. So we have more progress to make. And I hope to make as much progress as we can make between now and next Monday is in fact the day that has been identified. But we're certainly hopeful. But I don't want that to be a signal that in some way we're bringing forward next Monday to today and that we're ready to move. We still need to make the progress that we hope we can make over the remaining days.
Thank you.
Thank you.
Hi, good evening. Ian Bagley from the Irish Daily Mail. I was speaking to several GPs today who they were very frustrated at having to ring labs, often spending up to 2-3 hours a day looking for their patients' results. And some are actually waiting for more than 2 weeks to get a lab result. And they believe that 24 hours would be the ideal time. But is this, not 48 hours, would this be achievable?
Yeah, thank you. I take that. So, as I explained earlier, for the great majority of cases, for those non-complex contact tracing, we're uploading the results on the same day that or initially the contact tracing on the same day that the lab results are uploaded, and we've automated many of the negative contacts, so that, and that's about 96% of cases now, because the positivity rate has gone way down. So that's greatly accelerated the communication through the people. Now, for GPs who are understandably frustrated, and they've been incredibly supportive to all of us here and as part of the wider healthcare team throughout what has been a time of great uncertainty and rapid change, we hope to commence a helpline tomorrow directly for GPs where they can phone if there's any frustration at delayed results on behalf of their patients. So we're hoping that will be instigated the next day or two.
And it's mainly their frustration. It's mainly around even trying to get through to the labs in the first place.
Yes.
They feel that there's significant understaffment of
I completely understand that. As I said, we understand the pivotal role that GPs have in communicating the results to patients and in working with public health, to ensure that those critical measures are taken. And so for this purpose, following some dialogue with our John O'Brien and several key leads, Mel Bates, Ray Wally of the IMO and ICGP, we're hoping, as I say, to put a helpline directly for GPs so they can call with any questions they have about lay tests.
That's tomorrow, is it?
In next day or two, I hope.
Okay. And just my next question, it relates to the concern around the postponement of urgent medical services like cancer screening programs. And when can we expect a roadmap in place for the reinstatement of services like these?
Well, people have often used the phrase back to business as usual. Of course, it will never be business as usual again, because we're now dealing with we've managed with great efforts on behalf of everybody in society to reduce the number of cases out there in the community and to reduce the number of outbreaks, including in hospital settings. So bringing, in the case of screening, for example, which involves bringing healthy people in to ask them to engage in a test to find out whether or not they may have something they weren't familiar with or some precancerous changes. We have to take great care in starting these services up again to make sure that we don't bring people into an environment where we could, for example, in the worst case scenario, start another outbreak. And there are new restrictions in place. There's social distancing, and that will affect how people queue, how people wait in a waiting room. For the mobile van and breast screening, for example, it means that we can't countenance 40 patients per day. It will be reduced to a much smaller amount. For the very process of mammography and breast screening, which involves a very close contact between the radiographer and the patient, that will involve PPE and infection control prevention measures. So if you go beyond that, just one example of breast screening, and imagine how the other services, including cancer, time-related surgery and elective surgery, we have to give great consideration as to how we can safely and effectively reintroduce these in an incremental way, making sure we don't introduce a greater risk into hospitals, namely another outbreak of COVID-19. So I would like to assure people, anyone who's worried, is we are carrying out, we are engaging already with plans for cancer. Cancer activity is continuing. The drop-off and referral to our rapid access clinics has been marked, possibly reflecting a fear of patients going with symptoms to their doctor, and we want to encourage people with any symptoms that pertain to our rapid access clinics, including breast, lung, and prostate, and bowel, and so on, to go to their GP if they have suspicious symptoms, and those clinics are up and running. But as I say, the way we deliver those services, the way we deliver the follow-on service of diagnostics, of biopsies, of radiology, of surgery, will have changed. And I don't see them going back to the way things were a few months ago for a long time.
And Tony, my final question. I know you said that it wouldn't be advisable for people to travel from the 24th of June. And would you care to elaborate on that? Why don't you think that the country would be ready to go on their holidays by then?
I think we've got a bit more progress to make. Travel outside of the country obviously involves airline travel and social distancing in those kinds of environments. We think is going to be a challenge for people. What we'll also have to be conscious of is that this is a disease which is at a different point in different parts of the world. People travelling to different parts of the world that have higher levels of infection represent a risk in terms of bringing infection back into the country. If we make the progress that we're expecting to make, hoping to make as a country over the course of the remaining days between now and the 18th, if we're in a position to recommend easing of restrictions to government and we start the process of easing of restrictions, I think it will be because the disease transmission, if you like, is back at low levels, and that in relative terms, the risk of importation of infection becomes in relative terms more important in terms of a source of new infection. That's the experience of many of the countries that have already introduced restrictions and then eased those restrictions. The experience that they've had in terms of, and some have had this experience of extra cases, has come in some cases from importation from outside of those jurisdictions. It's one of the things that we have to be conscious of, and one of the reasons why we're saying we think we need to strengthen those arrangements. And as I say, the current arrangement now is that we recommend against non-essential travel outside of the island. We don't want to see Irish people planning to head abroad on holidays and then have to come back into the country where we're in a position where we might be contemplating some additional restrictions that might have to apply to those people.
And not mention any airline in particular, but what would your message be to airlines that are adamant to reintroduce flights?
Well, like we will have, as we do at the moment, clear public health advice in place. We have had good cooperation from airlines. It includes a range of different things, helping and facilitating the contact tracing processes right at the very beginning of all of this, helping to ensure that the messages in terms of public health messages get out to people who are using those services to help us in the process of ensuring that non-essential travel doesn't take place. We don't want to see people coming here at this moment in time who shouldn't be coming here or are not coming here for essential reasons. We don't want to see people who are from this country leaving for non-essential purposes at this moment in time. We think the airlines can facilitate and play a role in helping us in that respect. And airlines have been helping us with some of the very specific measures that have been put in place, like, for example, the passenger locator form, which is in place at the moment, and we want to see that being used and used more consistently. And that's one of the things that we're looking at. And then also to finally make the point that there are international health regulations that place obligations on airlines and others to facilitate public health authorities around the world in the spread and the containment of spread of infectious diseases that become globalized and are facilitated in their spread by airline travel and transportation and movement of people.
Okay, thank you.
Thank you.
Neil Leslie in the Mayor. Sorry, I think I'm last. I'll be brief. Oh, sorry, I'm not. Sorry, there was quite a note of caution struck last night around the figure of 43% of people thinking they were beyond the worst of the pandemic. I'm just wondering the type of figures that we have there, the 107 cases, the fact that the positivity rate is low, and you said that, that the health service, the testing capacity hasn't been overwhelmed with the opening up of the case definition. Are they not justifiable reasons for people to be optimistic ahead of next Monday?
I think that we can say certainly that people can be hopeful. We can say that we're making the kind of progress that we think we need to make. As I said, we look at a range of different things relating to the disease, relating to the capacity of the testing, sampling, contact tracing process that we've talked a lot about this evening. we look at the information that tells us about the levels of population behaviour, particularly the important behaviours that we think are going to be really significant as we move into an easing of restrictions. So as we increase the amount of movement of people, and people hopefully get back into both the economic and social activities that we want to get back to, maintaining really high levels of compliance, as the public has been doing so far with the measures around hand washing and all of that, respiratory etiquette, face coverings we're going to be talking about more, and maintaining social distancing, avoiding crowds. All of these measures are going to be really important in helping you to protect yourself as we move into this kind of phase. And we're confident that we will get high levels of compliance on the part of the public. But one of the things that did give us some disquiet in relation to that figure is a sense that that there is a view, and I've felt this myself in terms of my own engagements, that maybe a sense that we have passed this, the work that society had to do here that was set out for us in February as we faced this challenge across Europe and across the world has in some way been done. And that, you know, we're now ready to move on as a country, or we're ready to move on as a health service. The reality is that this virus and the real challenge that it poses for us is a relatively modest increase in the reproduction number, and we were showing you this. So if I took a figure of 200 cases, so let's say we were at 200 cases a day, and we're doing a little better than that at the moment, and if the reproduction number was to change to up to 1.6, which is not a very significant increase, that, we think, in a 3-week period, if it was sustained over that, would lead to something in the order of about 1,000 cases in a day, which would represent something in the order of 150 new people being presenting and admitted into our hospital system, and 20 additional admissions into intensive care units a day. So that's something that we wouldn't be able to manage with for any length of time. So we have to be very cautious as we step our way through this, that we don't see a sudden change occurring. And the reason that I'm particularly concerned about this one is we've spoken since the beginning about what we call anticipatory behaviour. As we strengthened our measures, the population was ahead of us, anticipated where we were going, and as I've used cocooning as the example, before we said on the 28th of March, now is the time for cocooning to start, many people in those groups had already made that decision, were already doing that. If we find ourselves as we ease restrictions, or even before we start to ease restrictions next Monday, the public gets ahead of us, and we start to see behaviours and activity of a kind that we haven't recommended, a riskier level of behaviour, a drop in the standards that the public has maintained in terms of their own self-protection. We think there's a real risk that greater levels of spread of infection could occur than we might be anticipating. That's why the reason that we have to be very sure that our systems to pick up these rates of infection are very responsive. But we want to be sure that that doesn't occur because people have a sense that this is work that we've done and that this virus isn't going to cause a problem again in the future. It is still there as a very real risk if we collectively get this wrong. And I have to be clear about that.
Okay, just the one specific suggestion that was made today around smoking areas in pubs outdoors, as a suggestion that they be made non-smoking to help with public health and measures and social distancing going forward. Is that something you might think is a good idea?
It would. The fewer facilities we have available to facilitate smoking, from my point of view, the better. Smoking is not an activity that we'd like to see the levels of smoking in the population driven down as much as possible. And cigarette smoke is something we know that the more we create environments where smoking is harder for people and where it's more of a challenge, the greater support that is for individuals who are trying to give up smoking, the less contact that people who don't smoke will have with the passive smoke, and the less exposure that young children will have to seeing people smoke and all of that.
And as a social distancing measure in itself beyond that, do you think it's a good idea?
And if that would help in terms of social distancing, even better.
Okay. And just finally, as it is International Nurses Day, we hear a lot from the health experts of the country. If the frontline staff could say something to people at this juncture in where we are, what do you think they'd say?
I think that they would really thank the public for the support. It has made a huge difference in our ability to continue to delivering care, and compliance with the measures that have been put in place is the best acknowledgement that we can get from the public and from everybody on a day like today. Thank you.
Thanks, Neil.
Thanks to David Quinn, Sunday Times. Just to follow up on what I was asking yesterday, which is an overly complicated way of asking it on my part. So over the last week, what percentage of the deaths recorded were associated with care homes?
Over the last week, I have that percentage here.
Okay.
I anticipate you
Yeah.
might ask me the question. Just give me a moment. So,
Sure.
over the course of the last week, the average percentage in respect of residential care facilities and was 68.1%.
Okay. Thank you. Now, does
And in respect of nursing homes, if that was the,
Yeah.
if I'm anticipating that
Yeah,
question,
yeah.
it was 64.2%.
So over the last week?
Over the last week.
Yeah, thank you.
Yeah.
Now, this is kind of a huge question, really. So I think you were saying, Dr. Henry, that you don't see cancer services going back to normal for a long time, I think. You were saying, and Dr. Holohan, you were saying that this herd immunity strategy might not work. There's a big question mark over it. And you know, a vaccine is, you know, goodness knows how long down the road. So it sounds like we're an awful long time, possibly, before we get back to normality, by which I mean pre-mid-March. And are the public going to have the patience for that? And given the enormous economic devastation there will be, you know, you must be concerned that at some point the public says enough is enough.
Well, I mean, we understand the challenge that these measures represent, and it is true to say that, like as we move through the easing of restrictions, we're heading back to a new normal. No country is in a position to confidently predict the point at which we'll be able to go back, as you're describing, to, if I can put it simply, I know these weren't your words, the way things used to be. This is a new virus. It represents a new challenge for mankind and for humanity, and learning to live with it. And the challenges it poses is something we're going to have to do. Even if we're on a path and we're hopeful to certain vaccine development, to an ability to be able to deploy that vaccine at scale, to make that available to the population, we're still some time away from that. From the point at which we have, as it were, the scientific breakthroughs.
I mean, that could be next year, the year after, though.
It could. And
the way
like,
things were.
Yeah, and the reality is that, like, every country in the world will be looking for this vaccine, that there will be a demand to have that vaccine obviously given to people in the highest priority groups. So some of the vulnerable groups that we've identified already here, people who are healthcare workers, will obviously be high priorities in the context of, so getting to a situation where we have sufficient in the way of global supply, and countries cooperating with each other in both the manufacture and the making available of that, rather than competing with each other, will all be very important in terms of global solidarity around all of this. But yes, it will be some time before we're in a position to say we have vaccine available to everyone. And that is contingent, if you like, on what is still an assumption that we will get an effective vaccine as a result of. And without saying I'm expressing doubt about it, nobody's in a position to express certainty about the availability of that yet. What the WHO has been reminding us of is that a strategy that's built on herd immunity in relation to this disease is still very much a theoretical concept, and the practical serological evidence that's accumulating around the world is suggesting that this is not likely to give substantial amounts of protection to the populations that have experienced this illness. And I think we have to listen to that advice. And what we have to do is emphasise the importance of the behaviours, both individually and collectively, that we have to have that minimise the risk of transmission of this virus. We have to work together as a global community to be able to do that, because there's little point in having, you know, some countries doing well in relation to the transmission while other neighbouring countries are not doing so well, and they continue to reinfect one another.
But won't populations, I mean, if this goes into next year and possibly even the year after, and we can't get back to the way things were, that the populations will simply say, you know what, we'll pay the price in terms of infections, because we want to get back, and we can't have the economy and society being so devastated.
Yeah, we're not going to be able to, the world is not going to be able to maintain economic activity at the depressed levels that it's at the moment, social activity at the depressed levels that it's at the moment. All of this is for the purpose of getting us into a situation as individual countries and as a global community whereby we control and limit the spread of this infection and find ways of adapting then as communities to dealing with this virus and the risks that are posed by it. And it won't be the case that countries are in a position to maintain depressed economies for long and extended periods of time. But no more than, if you like, society in general, we know that, like, workplaces, workplace settings are going to find ways of innovating and adapting to the presence of this virus. I mean, this is already happening. in the sense that we know that organisations, if I can put that, including the one I work in myself, is finding ways of adapting and working in an environment where actually we want to limit the extent to which people come together to as few occasions as possible. And we think we can do that. Many businesses, many organisations will be in a position to do that. We'll continue to say, I think, where people can do that, that will be the recommended way of ensuring that your staff, your customers and so on, your clients are protected. And these are the kinds of adaptations in the workplace and in society that I think we're going to be finding ways of living with. And as I say, around the world, and not just in this country, people are finding ways of, as it were, re-engineering, if I could use that grandiose word, either society or workplaces or social environments in ways to maintain activity, to reintroduce activity, while minimise the risk of transmission of this virus. And we're going to have to learn to be good at that, while maintaining the high levels of compliance with the behaviours we've talked about around respiratory etiquette and hand washing and so on, until such time as we can find hopefully our way to an effective vaccine that we can make available to people.
Okay. Thank you.
Thanks, David.